Okay, we're going to get started. Thank you all for coming. I'm Michael Perskin, and this is the symposium, special symposium on the business of medicine, making change happen. I'm from NYU, and we're going to have several speakers, so thank you all for coming. And hold on, we're going to get there. Okay, so here are our goals and objectives, and you can read it as well as I can say it. But basically, we're gonna hear from a few leaders of healthcare organizations about how decisions can be made in this changing healthcare environment that we are in, how they might do that, and I might talk a little bit about that, to understand how financial incentives impact organizations, and finally to appreciate how health system executives view and respond to tensions between business realities and the missions of academic medical centers. So I come at this someone who started a multi-specialty group practice, and now I'm associate chair for clinical affairs of an academic medical center. And as I was telling my colleagues, Rulon Stacey, Dr. Stacey, and Dr. Jane Brock, who I'll talk to you more about in a minute, I have a radio show which I moderate every week, so this is pretty basic for me. In terms of how I got to this, so the next slide is an example of how a dramatic situation was resolved. There was tension between two groups of people in an organization around a quality improvement project, and in a historical tour de force. The clip I'm going to show you is probably 30 or 40 generations later, developed a technology which allowed me to, download this clip from YouTube and put it embedded in some PowerPoint slide and show it to you. And it's also personally the reason why I'm a doctor, because this was really the job I wanted to do. Let's see if I can get this. This will be exciting. Nope. Hold on. There we go. I hope we have some audio. There we go.
Take it easy with that.
Where are you planning on putting the window?
Window?
There's no window.
No window. What about the hatch?
The hatch.
Yeah, the hatch. We need a hatch with explosive bolts that we can open ourselves.
I think there is something you do not understand. This is the final form of the capsule. No hatch.
What would happen if the automatic controls went out?
Backups, checks, etc. This would not happen.
I said, what would happen if it did?
Pilot would have to fly it back.
This is the way it is.
You know, I wonder how the press is going to feel about that.
Press? What does the press have to say about it?
Yeah, what do they have to say about it?
Well, do you boys know what makes this bird go up? Funding makes this bird go up.
That's right. No bucks. No Buck Rogers.
And, press over there.
So, no Bucks, no Buck Rogers. The way I actually remembered it was, funding makes this bird fly, but it was close enough. And I think about it a lot in discussions with my academic colleagues and hospital leadership and other funders sometimes. So it's an important construct to learn, because really that's part of the crisis that we kind of face in delivering health care to the population. And so the next slide, if you combine what I just showed you with this, is what I also do is geriatric medicine. And if you look at the blue line and the green line, and now, so starting about last year, 11,000 baby boomers a day turned 65, and we know that a lot of healthcare costs are born from that population, and particularly in the age 85 and over population, which it doesn't look so steep, but it's really steep, and after 2030, it gets a little out of control based on current projections. This is a slide that made me go into geriatrics only because I thought there would always be more and more people for me to take care of when I got older. So, what happens? So we have all those people, right? And I like this as a PowerPoint template, right? So it's the gears of academia, business, and government, right? Government's bigger than the other two, and then really bigger than the whole slide is the patient base, right? So they're really what's driving change. But somehow the two smaller wheels, academics and business, have to kind of get along together, and the gears shouldn't grind, they should synchronize. So what happens? So when these groups get together, they come out with things like the guiding principles in 1999, right, from the Institute of Medicine, and everyone here knows these principles of safety, effectiveness, patient-centeredness, timeliness, efficiency, and equitableness, right? And so a lot of the initiatives and research projects I've seen so far today here speak to these values, and that's in 1999. So I showed you a clip from The Right Stuff, which was a book written in 1979 by Tom Wolfe, made into a movie in 1983. And really, the space program was really an early quality improvement project. A lot of things were developed, including a lot of computer technology. But this is a slide which was an ad from the Ford Motor Company, and you can see quality is job one. And I don't think quality was a huge topic in medicine when this ad was in magazines, right? There was no internet, of course, in 1982. There was television and magazines, and that's when it's from, 1982. So business actually has been in the quality sphere longer than medicine, right? Which kind of came on 1999. We decided we better do something about our quality. So we're really almost 20 years behind the business community. So that's why I think we actually have some things to learn from our colleagues on the business side of things, including a lot of the quality improvement work that we all do using Six Sigma or lean management techniques. So I believe we're only going to have 2 speakers today. I'm not certain what happened to Dr. McGinn, but we're going to have Dr. Jane Brock, who is Chief Medical Officer of the Colorado Foundation for Medical Care, and she is going to talk about the hottest topic in medical care today, readmissions and penalties. We're also going to have Dr. Rulon Stacy, who's the president of the University of Colorado Health, and I hope to moderate a good discussion over the next 80 minutes or so. And so what we'll do is we'll have maybe one question in between or 2, and then we'll move on, and then we'll have a broader discussion after both talks. So without further ado, Dr. Brock. Hold on. No. There we go. I'm going to do this for you.
Thank you.
Thank you.
Thank you. It's a pleasure to be here today to talk to you all. Who here is a physician? Is basically everybody here a physician? And what proportion of you practice in a primary care environment? And what proportion of you practice in a hospital? So it seems like most do both, maybe half do both. Okay, so I work for a Medicare Quality Improvement Organization. So in case you don't know, Medicare funds a single quality improvement contract in every state. So some companies who hold that contract hold multiple state contracts. But the Colorado Foundation for Medical Care, where I work, is the quality improvement organization, the Medicare Quality Improvement Organization for Colorado. So we've spent about the last 6 years working on hospital readmissions. So not only do we work in Colorado, we have the sort of national coordinating contract for all of the QIO work nationally on reducing hospital readmissions. So I'm just going to give you sort of an overview of what I know and part of what I think, and then I'll look forward to your questions. So it seems like hospital readmissions are the hottest topic in healthcare reform, and I feel like this kind of entered the general public commentary. It probably isn't truly public, but anyway, physicians, hospitals, and policymakers. When Jenks, Coleman, and Williams published this in the New England Journal in 2009, showing that 1 in 5 Medicare beneficiaries is readmitted to the hospital within 30 days of being discharged. So if that was any other product, and it looks like there was a 20% failure rate, that would be a problem for that company. What really got everybody's attention is that the $17.4 billion a year spent on caring for patients during hospital readmissions. So interestingly, if you research the history of hospital readmissions, which people like me who are totally steeped in readmissions find that interesting, actually. But there's a paper published in 1984, Jerry Anderson, I think he was at Rand at the time, who did almost exactly this same study. And do you know what they found in 1984, what the readmission rate was? Anybody know? Yeah, 20%. So like apparently nothing's changed in about 20 years, except for one thing. And what changed is this paper came out during the time the Affordable Care Act was being written, and policymakers, seized hold of this. And of course, even before the ACA was out, there was this sense that there would be payment penalties for readmissions in the near future. Anyway, so the penalties started in October, starting with discharges in October of 2012. There are 2,200 hospitals basically taking penalties. My understanding is the average penalty, is about $125,000 a year. So there's a lot of feeling that that's not enough. But the way the Affordable Care Act is handling penalties, those penalties will increase over the next couple of years. It's Section 3025, if you all are not totally familiar with this and want to look up the original language. But in brief, the penalties that hospitals started taking in October, are based on their discharge profile from 2008 to 2011. So it's a 3-year period on which this penalty is based. So your average hospital that you're discharging from or admitting to today is perhaps functioning under a penalty based on their discharges from what seems like remote history. So for the diagnoses of AMI, heart failure, and pneumonia, and I want to emphasize this is all readmissions after a discharge for one of those 3 conditions. There is an excess readmission ratio calculated for that hospital, and that is basically observed over expected. Those 3 penalties, the penalties for each 3 type of discharges, so for AMI, heart failure, and pneumonia, are essentially averaged, and that calculates your excess readmissions ratio. 1 minus that is how your payment is adjusted. So if you have really low readmissions in pneumonia and sort of high readmissions in heart failure, you could average out to be not getting a penalty. The other thing to know is, so we have the National Medicare Part A claims file, and the average hospital AMI, heart failure, and pneumonia discharges are less than 15% of all hospital discharges. So hospitals are taking penalties based on this subset of folks. The penalty affects their entire book of business. So if you have a 0.01 penalty, that means that the payment of everything to that hospital, radiology, whatever, is reduced by that same amount. So there is nothing which penalizes or does not pay for any given readmission. This is a common misconception. Every readmission is paid for. That hospital stay is paid for. And part of the reason is because something like 25% of all readmissions nationally are to a different hospital. So when you start to think about how you would, regulate that, it doesn't seem fair that the second hospital sort of takes the penalty. So the way it's being applied now is if you have an excess readmissions ratio, the hospital across the board takes that percent reduction in total payment. So the cap right now is 1%. However, it goes up to 2% next year, 3% after that, and there will be additional clinical conditions added. In the law, it says, quote, at the discretion of the secretary, unquote. So, we don't know. I'm pretty sure that CABG and hip replacement surgery is being added next. I think that's going to start in 2014. So they're bundled over 3 years. So these hospital readmissions measures were made to be very, very stable. So that's why they bundle across 3 years, risk adjust, standardized to the national mean, and then calculate this excess readmission ratio over a 3-year period. So in a way that's good. So it's not like you could have just a bad quarter or maybe 2 or 3 patients who got admitted a whole bunch of times and that's driving your readmission penalty. So they were made to be stable to avoid that kind of scenario. On the other hand, this stability means if you did poorly in 2011, you're going to live with that figure for 3 years, going forward. In terms of looking at, I work for quality improvement, so we entered this work in trying to understand interventions that would change readmissions. I have a whole review of the literature, which is far too much to go into, but just to summarize what we know about readmissions and what, where they come from, that sort of thing. Okay, they're prevalent and costly. We've known that since 1984, apparently. In situations where they've looked at adverse events within 30 days of hospital discharge, first of all, they're very common. Something like 20 to 25% of people will say they experienced an adverse event following discharge, and they are associated with readmissions. About a quarter of the folks who say they had an adverse event will end up being readmitted. When patients are readmitted, they're not taking the meds that you thought they were going to be taking when you discharged them. It's something like a third of the medications do not match up when you look at discharge meds versus meds at readmission or at first physician follow-up. When people leave the hospital with recommendations for further follow-up on a test or further workup, those are very commonly not recorded in the physician who receives medical responsibility, so that the outpatient doc's notes. If there's a recommendation for follow-up, like patient discharged stable with regard to their TIA, needs colonoscopy, if that is not followed up, that's 6 times more likely to result in a readmission. All of the work around looking at hospital to receiver, meaning discharge from the hospital, being medical responsibility transferred to fill in the blank, a SNF or a primary care physician. All the studies of that show that direct communication is recorded anyway, something like 20% of the time at best. So we know that this direct communication at the time of discharge is very problematic. However, there are some studies showing that patients, even with communication to the primary care physician, they are less likely to be readmitted if they are followed up by the hospital clinic, hospitalist outpatient clinic. So I include this for those of you who work in the outpatient setting. If you don't want the hospital to take over this role, and I don't know what's right, honestly, hospitals are very much moving in this direction, having their own discharge follow-up clinics. Creating the perfect in-house discharge process, so discharge standardization, is certainly a good idea, but is not very related to readmission rates. So doing the best you can in-house is certainly something that everybody should strive for. But if you don't build the bridge to the receiver, that's where the real payoff is in reducing readmissions. Socioeconomic status in every study done is related to readmission risk, but is not calculated in the hospital compare measure, the measures on which the penalties are based. So there's been a lot of discussion about that, and there's a lot of reasons for that, which I'd be happy to answer questions if you have them. However, it doesn't explain as much risk as you might think. It's about, in the risk prediction models, SES is about maybe another 4% worth of explanatory risk. In terms of identifying risk of readmission at the time of discharge, there's a bunch of models out there where people, you add the sodium plus the age plus how many times they've been in the hospital plus et cetera, and you come up with a risk criteria score. The very best of those have a C statistic of around 0.65 to 0.7. That includes the risk adjustment method for the measures in hospital compare. So that means it miscategorizes about 30% of the patients. They're just ideal risk prediction tools are really not widely available. All right, so the work that we did in the quality improvement organizations and that we are doing today, we just published the results of our pilot study, which is now being replicated nationally. CMS funded 14 QIOs to recruit a single community in their state to reduce the readmission rate for the population that lives there. This was our very first ever foray into population-based improvement. Anyway, a section of Denver was part of this work. This was covered about 800,000 Medicare beneficiaries who were living in one of these 14 communities, where the local QIO got funding to reduce readmissions for population that lived there. At the end of that work, this is what we call our driver diagram. If you want to know why people are readmitted, when we did a lot of medical record reviews and process mapping, that sort of thing, at the patient-provider interface, it always sorts into one of these 3 things. People go home and do not manage condition worsening. There's a lot of reasons why they don't do that, but they go home, figure it'll get better until they're wheezing so badly that they call 911. Secondly, they're not taking the medications that, as a physician, we all might feel would be the ideal thing for them to take. And thirdly, they choose over and over to return to an emergency department. And in the end, this is a very powerful place to intervene. By the way, we have known these things forever. I'm sure this doesn't surprise anybody here, right? These are basically, you always find one or more of these reasons. If you ask why again, it's because at the system level, and I call it system in a spirit of optimism, in a lot of places there really is no systemness to how the whole spectrum of care functions together. It's unusual to have sat down with your colleagues who do not work for the same institution that you work for to intentionally design a process for transferring medical responsibility. So, in any other industry, this would be just basic supply chain management. We're doing it now because of the pressure from readmissions penalties. Secondly, clinical information, even if there is a comprehensive clinical plan of care that has input from the patient and family, which I would say we have a lot of work to do on that, but even if there is, transferring that around among all the medical providers who may have further input into this plan of care is problematic in most markets. And then thirdly, patients, their confidence in their own capability to self-manage is really takes a hit just from being hospitalized. And the way the whole hospitalization to discharge process, much as we pay a lot of lip service to getting patients engaged, it is inherently a disengaging experience. And people, they just go home and they sit on it wheezing until it's so bad they call the ambulance and come back. So we've known, not only have we known that these are the basic problems for at least 20 years, there's a lot of public domain tools for addressing all three of these drivers. They're free. You could just download them and start on any one of these for quality improvement. So we had to ask the question at the beginning of our work, why has it not happened? And the question in 14 out of 14 communities, and now like 350 out of 350 communities, is that there's really no community infrastructure, and by that I mean no standing meeting at which people get together. So I have a dream where, the tumor board rounds that always happen in the basement of a hospital, where you have the multi-system people come and dissect a case. So, there's no usual place where you go to have transitions rounds where people say, didn't you get this? What happened? What did you think when where people can hold each other accountable for, you didn't tell me what I needed to know, or you gave me so much information I couldn't find it, or you did give me the information and I didn't follow up, or you know what I mean? There's no place where people sit down with the intention of improving this situation. So in our work, the QIOs basically formed the role of organizing the community. In a sense. Many providers are serving the same population of patients, and although they know that, they often have never met each other or sat down to work on it. So increasingly, we took the role of basically hosting meetings at which people could talk about it. The providers did the interventions. Most providers are doing interventions right now to reduce readmissions, so it's not like anybody needs a new intervention. What they need is a place to leverage their intervention with their partners for mutual and rapid improvement. In the communities that did well, essentially the projects went along on two simultaneous tracks. What you need is patients who are capable of crossing the bridge. So, patient activation, people who really have the capacity to engage in their own self-management. On the other hand, we shouldn't have to expect them to be tightrope walkers. Some people can get to that skill. We also could just build a better bridge. We need better processes, easier processes, better communication exchange, and we need to be sure that we are getting to the optimum capabilities of people to self-manage as they navigate this bridge. The evidence-based interventions that were the most used in these 14 communities are these. Hospital discharge standardization protocols, I think they're absolutely necessary but insufficient. And most of those are Project Red or Boost. I'd be happy to talk about those more if you want. The care transitions intervention is in red. That's the one that really bore the most fruit. That is a patient coaching intervention to get patients to optimum self-management capacity. The transitional care nursing model is a bridging nurse function where you have a nurse that sees them in the hospital, sees them at home, and accompanies them to their early follow-up visits. And then the Interact Toolkit, if you're not aware of this one, is, to me, absolutely crucial. This is a way for hospitals and nursing homes, skilled nursing facilities, to standardize the way they communicate and transfer among themselves. Here's what happened. Here's our interim quarterly results. So we had been working on this for a year, and we were using the measure similar to the measure on Hospital Compare, the metric that everybody's using to measure readmissions, which is number of readmissions within 30 days divided by number of discharges. All right, here's what we found 1 year into our study. We were, as you can tell, failing. This rate had gone way up. However, as you can see in the blue box, we had reduced the number of readmissions generated by these communities by something like 800 in the first year of the project. So this is when we started to realize, oh my gosh, when you first start on this work, so what 20% readmission rate means is 20% of the folks in your hospital today are 30-day readmissions. And when you interrupt that door, the first thing that happens is your discharges drop by roughly the same amount. So we saw that they were going down together. Now, this is starting to reverse, and I can talk about that later if you have questions about it. But anyway, so we were allowed to measure our progress based on readmissions per 1,000 people in the community at risk of admission. So when you think about it, if you live and work in a community in which there's great outpatient chronic disease management, and people don't get to the hospital very often, if your admissions per 1,000 are like 4, really, why should we care how many of them are readmitted? Readmit all of them. You're obviously not using acute care services too much. So anyway, CMS is aware of this potential problem with the measure, but anyway, so here's our results. The communities, the 14 communities in red started out at having higher readmissions per 1,000 compared to a sample of comparison communities. Once the community coalitions were formed and the interventions were being sort of leveraged across settings, you can see those lines crossed. The readmissions went down by about 6%. It was statistically different than what happened in the comparison communities. Now, you will also note that the readmissions per 1,000 is going down everywhere. It went down in the comparison communities as well, just not as much. So the readmissions per discharge measure, however, didn't change anywhere. So when you read those news blasts saying that despite a lot of attention, readmissions in the U.S. are not going down, it is that readmissions per discharges measure. And at some point, we're going to have to figure out how to bring these two bodies of knowledge together. So the hospital compare measure on which hospitals are being penalized, readmissions per discharge, those are disease-specific, risk-adjusted, and standardized to the national mean. We found them to not be useful for tracking improvement. If you're working on improvement initiatives, what we found was readmissions per 1,000 was much more sensitive to change. As I said, the hospital compare measures were designed to be insensitive to change, to be stable, because they are designed to evaluate the performance of hospitals and compare them to each other. If you want to track improvement, you just need to count readmissions over the population at risk. So we use them unadjusted. We found there's a tremendous benefit in using geographic measures in that you can display them publicly. They don't identify a patient or a provider. They're a great unifying measure for providers to work together. One of the main things we discovered is we could capture the benefits of the non-medical service sector. So in the end, one of the most important discoveries in our work was that a lot of what determines whether people come back or not is the social environment that their home is located in. So I know I made comments earlier about socioeconomic status. Although socioeconomic status of the individual may have some importance, I actually think it's the socioeconomic status of the neighborhood they return to in many cases that puts them at risk. We're trying to do analyses to really kind of dig into this, but if you have no capacity for self-care and social support in the neighborhood you go home to, then you call 911 because that's your only option. All right, so what a physician could do, certainly if you're not familiar with whether or not your hospital is getting a penalty, that'd be a good thing to know. If you keep patients out of the hospital with chronic disease in the first place, they're not eligible to be readmitted, having not been admitted. I think physicians need to really think carefully about their role in both ensuring a quality transfer into the hospital. There's a lot of literature that shows the quality of the discharge reflects the quality of the admission. We need to figure out what is the role of primary care physicians in follow-up. If that is not an achievable thing, then the hospital should develop a follow-up clinic to take on that role, and the transition should happen after that. Certainly there's a lot of resources showing that coding for heart failure is way off. And a lot of the readmissions for heart failure probably shouldn't be readmissions for heart failure because they probably weren't heart failure really when they were discharged, much less when they were readmitted. Certainly physicians have a very important role to support patient self-management capacity during their follow-up visits. That's the time when they can start to re-engage. You know, they're starting to recover from the trauma of having essentially failed to self-manage before, which is what put them in the hospital. And then if your community is going forward in a cross-continuum or community-based initiative, I think that physicians have a very important role to play there, but often are inaccessible. And I know we would value more physician participation in our work. So thank you. I'm going to stop there.
Okay. Dr. Bach, thank you very much. So I thought that was a great talk, and I'll ask a question to the audience, actually, about the last point you made. How many, out of curiosity here, can have real-time data of who goes to the hospital or emergency room from their patient panels? Anyone? That's pretty good. Even outside of your own institution? Right, so just anyone outside of their institution? That's pretty good. Where is that?
Are you in Indianapolis? Oh, yeah. Very good.
Yeah, so that's pretty interesting because I think, that's what seems to be, to me, the difficulty. So I can track of my patients who are in our hospital, but I know that 50% are in other hospitals. Roland, do you have a question or comment at this time? Maybe I'll ask you one more question.
Yeah.
So you also mentioned about unsupported patient activities and activations and information transfer. So, I think it's a common experience of primary care docs that you get pieces of paper or information from the patient or their family, and these are the people least able to actually transfer the proper information. Doc, they told me to give you this piece of paper type of thing. So my question is, do you think that the policy prescription enabling health information exchange is a good one to help that information transfer?
Yeah, that's a great question. I think there are two critical types of information transfer that need to occur between a patient and physician after discharge. So one is if you're going to be managing a patient, you absolutely need to have robust and accurate information about the medical management of that patient by the previous folks who adjusted them. And that to me is a clinical information transfer, and that's absolutely critical. And as I said before, I think there's a huge gap to begin with in us developing good overall longitudinal care plans to begin with in order to transfer them. But equally as critical is having patients give their input on their goals, what they value out of their health, and what they intend to achieve, and what they know, think, and value. And that is one of the cornerstones of the coaching intervention. There's just so much evidence that we design perfect plans for patients that are not important to them and or that they're not capable of doing anyway. And so a part of the coaching intervention is to have patients develop their own personal health record, which only they can record in, reflecting their understanding of what they are to do and how it does or does not serve their own self-identified goals for their health. So,
thank you. And so now we'll have Dr. Stacy. Dr. Stacy is the CEO of the University of Colorado Health Organization. I appreciate him taking the time to come. And his talk is, hold on, I have it. A transformational relationship. Yes?
Could I ask a quick question?
Sure.
Dr. Brooks? Hello, how are you doing? My name is Neil Shaw. I'm a third-year resident at Tulane. I'm going to be starting at a hospitalist position in July. And my question's regarding you alluded to it, how successful have specific discharge clinics been? Particularly with, there's a lot, I don't know about all the national statistics, but what I'm hearing a lot is there's a shift towards a lot more hospitalist and just primary care as opposed to the traditional, physicians taking care of the patients in the hospital now. But for the specific hospitalist programs, how successful are specific discharge clinics? And what's is the reimbursement taken care of by Medicare, Medicaid for these clinics if it's not their primary care doctor?
Unfortunately, I can't speak to the reimbursement for the hospital-based discharge clinics, but yes, there is a preponderance of evidence that they probably do have an impact on readmissions. So I can just say I personally am of mixed feelings about this. Probably part of the reason that they are more effective is because the hospital has the right information. Mm-hmm. So at the time of follow-up, the hospitalist knows what happened to the patient and has that hospital record. So when you think about it, if primary care physicians in a community want to take on this role, there's no reason why we couldn't make sure that they also have the same understanding. But yes, so far, hospital discharge follow-up clinics, they look like they do reduce readmission rates by, as much as 15-20%. They can.
Thank you very much.
Thank you. So Dr. Stacy?
Thank you. It's a great opportunity to be here and to listen to Dr. Brock speak. We are all spending our careers learning how to suck up to Dr. Brock. So it's an important part of our life to hear what she's thinking. So my goal today is to describe a little bit about my opinion. I like talking in a group like this because I am certain I will never see any of you again in my life, so I don't actually care what you think about my presentation today. I can say anything I want. Well, that's not true, except for I got to suck up to Dr. Brock. We've had that conversation, right? So I want to talk a little bit about what I think has driven success in the past and where I think success for the industry and for organizations and for physicians will be in the future. And I'm going to slip through a bunch of these slides to get to my point and make sure that we have time at the end for questions. First, I want to talk to you a little bit about what Poudre Valley Health System did several years ago. Poudre Valley Health System, you just heard I'm president of University of Colorado Health. University of Colorado Health was created just last year through the merger of University of Colorado Hospital and Poudre Valley Health System, a system in northern Colorado that consists of this service area, a couple of hospitals, one in Loveland, one in Fort Collins. And shortly after our merger, we acquired the Memorial Health System in Colorado Springs, which is 2 hospitals in Colorado Springs, and then in January, Ivinson Memorial Hospital in Laramie, Wyoming joined the system as a managed hospital. We started our philosophy years ago to focus on one thing, and that was providing world-class care. To us, that meant that we performed in the top 10% of all available national database in clinical outcomes. That's what we wanted to do and what we wanted to be. And at the time, for us, a comparatively small hospital in the middle of nowhere, that was a big goal and important for us. So we established a process whereby we could follow, where each person in our organization would understand what our vision was, what the strategic objectives were that our organization was going to pursue to achieve that vision, and then what each unit in the organization had to specifically do to do that. For us, it allowed us a chance to get everybody involved to communicate exactly what we were doing through these 6 strategic objectives and get everybody on board. I told our employees that we expected them to give the very best care that our patients had ever received. But to do that, I was fully prepared to accept the responsibility to make this the very best job that they had ever received. And if it wasn't the very best job they'd ever worked at, they needed to come and talk to me, and we would fix that so that we could focus on one thing, and that was on our patients going forward. And so we worked to move that through the organization, get everybody on board, and find ways to partner. And this is one of the points I wanted to make, that for us, partnering in what we did was important. We wanted to find ways to align incentives. This was in the late 1990s, and so we felt like for us to be successful clinically, we first had to be successful economically. I believe we find ourselves in that kind of a position today. As noble as each of us are, none of us is going to work for free. And we have to find out what are the ways to align incentives. This is how we did it in 1999, or the late 1990s, by finding ways to partner economically with our physicians, to get on the same path with the physicians economically so that we could be at the table when we talked about clinical outcomes. I'm a firm believer in the saying that if you are not at the table, then you are on the menu. And I really believe that. I think if you can't talk with somebody toward a common goal, they're going to talk with somebody else toward that common goal without you. So that's what I think we're successful in doing at the time, is finding ways to partner economically through joint ventures and other relationships with our physicians toward the common goal of partnering improving, and the iterative improvement process. Now today we find ourselves in a different situation. I'm going to talk a little bit about some of the details of this in a few minutes, but we now have a group of employed physicians called the Colorado Medical Group, Colorado Health Medical Group. We have really now about 200 clinicians, actually about 200 physicians and about 50 mid-level practitioners, 27 clinics, and it's been an important part of our development as we find new and innovative ways to partner with what we're trying to do going forward. We also found that this kind of partnership helped us on a regional basis. This idea of partnership helped us on a regional basis. We built a new hospital in northern Colorado, and we approached all of the other hospitals in the region, in the rural parts of Nebraska, Colorado, and Wyoming, and said, rather than all of us build new hospitals and create new services, let's build one and we'll all own a part of it. And so the only hospital that took us up on it was Regional West Hospital in Scottsbluff, Nebraska. They own now 12% of this hospital in Loveland, Colorado. But this hospital is going to do 350 open heart surgeries. It's the second busiest heart program in the state of Colorado, whereas if Regional West would have started their own program, they would have had 30 or 40 or 50 open heart surgeries. And ironically, you can make money doing that, but I think we would all agree that that's clinically a tough way to run a heart program with that many. So by coming together, we were able to do that. And that led us to the relationship that we currently have with University of Colorado Hospital. The future for us is moving now from independent to interdependent. The future is providing care that is accountable, and we have all got to find ways to be more accountable for our care, because there are people who are going to ask us about our readmission rates, and they have every right to do so. And we've got to be able to be accountable for that, and none of us can do that independently. So we've got to find ways for hospitals and doctors and pharmacies and rehab providers and everybody else to work on a closer basis than we have ever in the past. That's why in the future these kinds of partnerships are so critical, and why you'll see today, I've got a slide on this in a minute, about why there are so many mergers and acquisitions and partnerships in healthcare. What we did to measure this in our organization was to create a balanced scorecard where we would go down every clinical area and identify where we were meeting our target and where we weren't meeting our target. And where we weren't meeting our target, we would have, we would make sure that we mandated action plans to identify improvements. If our readmission rate was below target, we had to have an internal measure to fix that, because we knew that first it was the right thing to do. It's just good clinical care, and we were fixated on world-class healthcare. That's all the reason we were in business. Plus, oh, by the way, we knew that at some point our reimbursement would be based on that. And for us to be successful financially, we had to be able to figure out how to do that. And we wanted to bring our people along. So we applied for the Malcolm Baldrige National Quality Award, and in 2008 we're fortunate enough to receive that award. The important thing for us is that as we started to identify areas of improvement and opportunities, we got a little bit better every year. This is the score every year from our Baldrige survey. And then you can see what happened with our outcomes and why it was so important for us to do that, and why I think it was such an important precursor to where healthcare is going in the future. We wanted to focus on being in the top 10%. Before we made that decision, we were happy to be above average. And I've often wondered what would happen had we always been satisfied with average, especially when you look at data like this mortality rate. These are people who are alive because this organization made that kind of effort. This is our patient satisfaction scores. Press Ganey will tell you that fewer than 2% of organizations can sustain customer satisfaction, patient satisfaction, improvement for 3 consecutive years. We just finished our 11th consecutive year of improvement because of the iterative process of identifying and getting better. Our financial markets and targets were the same. This is our employee satisfaction. Remember, I told our employees this has got to be the single best place you've ever worked, and the way we measure that is by employee turnover. At the time, it was 25%. There is nothing that will hinder financial and clinical progress like a 25% turnover rate. And because typically when you lose 25%, not only are you losing 25% of your workforce, but a substantial portion of those that leave are your most experienced, and that's devastating clinically, and you just can't have that. And so we measure that. In the last few years, we've bumped up for two reasons, because as we prepare for healthcare reform, we've consciously reduced our staffing levels because we can't be as luxurious as we were on staffing and be financially successful in the era of healthcare reform. And we can't, in the year before that, we brought on so many physician clinics that there was inherently some turnover in that. You've seen that slide. So that was our goal. So now where are we going with this? What is the future? What do we want to be when we grow up? This was a survey that came out just last month from Health Executive magazine about the health executives addressing what are the top issues facing hospitals and healthcare today. So if you want to know what your hospital administrators are thinking, this is generally it. The top issue in both 2011 and 2012 is creating an accountable care organization. How are we going to work with other people to be successful in the future? We have created, and oh, by the way, so have you, created systems that thrive on independence. And now we've got a system that will pay on interdependence. We've created a system that is destined for failure unless we work collaboratively to fix it. And we've all self-selected out the people who are the most independent of the independent, and we've got to figure out a way to fix that. So we're worried about accountable care organizations. Population health management is a big one that we just have to figure out how to take care of huge populations and address some of those things going forward. Some of the financial challenges: Medicaid reimbursement, government funding cuts, Medicare reimbursement, bad debt, decreasing inpatient volume, which is interesting if you go back and you see population health management as the number 3. That doesn't actually make sense if you're worried about inpatient volume, but they're hospital administrators. I can't speak for it. I don't know. Healthcare reform implementation, reducing costs, and the patient safety and quality from hospital administrators is the number one thing, is how do we engage physicians in improving a culture of quality? What can we do? Hospital administrators are there. What do we do in the future to actively engage the physician community in making sure that we focus on quality of care? And I would predict that the administrators that you work with, if they haven't said this, are worried about it, and it would be in your best interest to create the dialogue, because I predict they will be willing to listen to the dialogue as they improve the culture of quality and redesign the delivery process. So this is some of the things that are happening in the healthcare market today, and it's some of the mergers and acquisitions. In 2012, there were more mergers and acquisitions in the healthcare industry than ever before in history in the United States. We are on a path right now that by June of this year, we will surpass the total in 2012. So organizations, healthcare organizations across the country are deciding that we can't go this alone. We have to have a partner. Who is that partner going to be? And if we have to pick a partner, then let's compare their DNA with our DNA to make sure that we think the same, and as we create a new culture, that it's not so divergent that we become one of the 50% of mergers to fall apart. To do that, we have to prepare ourselves for the two-curve scenario, where we've been working forever. In fact, let me show you. This is the the theory. You've probably seen this a million times yourself. But for the last 100 years, we've been working under an environment where the more we did, the more we got paid. It was in our collective financial best interest to feed everybody bratwurst and pray that they got heart disease, right? That would pay us the most. Let's get them sick and then we'll fix them. That's curve one. The way we get better is by providing services. Rejoice when people get to the procedural years and we can just do whatever we want to do. That's what built so many hospitals. That changes now. Now we're going to have to shift to curve two and move from a fee-for-service system to a fee-for-value system. And we have to be accountable for the services we provide, and we have to provide a specific value, keep people healthy. And so the benefit of curve two is completely different than curve one. The problem is that our payment structure is still generally focused, not exclusively, but generally focused on curve one. So we're being paid to fix people when they're sick while preparing for a system to keep people healthy. And what we've got to do, what I would beg you to do as a hospital administrator, is help me find things that will work under both curves. What can I do today under curve one that will also work under curve two? Because I can't switch to curve two today. That would be noble, but we'd be bankrupt in a year. So I can't do that. What I can do is prepare effectively today so that when the time comes to make that jump, I can jump quickly. And population health, management, other things like that are things that we can do to prepare for that, and that's things that I think are in your future and things that we can do collectively to address that. One of the things is that we have to just realize is the change in the physician workforce. 2008 was a big year. I don't know if you noticed the bump in the road in 2008, but in 2008 in the United States, that's when more physicians were employed by hospitals than were in private practice. That's when the lines crossed, and they've been separating ever since. And that is a new dynamic in healthcare. Today, 70% of the residents who come out of medical school have no intention of joining a private practice. They want to be employed by somebody, come do their job, and go. That's just the change in the dynamics that we face today as we try and address some of those things. In Colorado, several organizations are leading the way in trying to address some of these population health management issues that we think we have to be prepared for. One of them is this. Interestingly enough, probably won't come as a surprise to you. I suspect each of you live this every day. But 1% of the population accounts for 26% of the hospital expenditures. There is a health system who was presenting at a conference that I was at, and they said that they had one patient who came to the emergency room in the last year 302 times. Well, that's like every darn day, right? That they're living in the emergency room. And so the newest method for people like me to address this going forward is to hire specialists who can help us manage those people. It's cheaper for me, the cost for that person to come into the ER every day was more than $5 million. So that's one person at $5 million. I can hire a lot of people to help that person stay out of the ER and keep healthy. I could hire a team to stay in their home and keep them healthy as opposed to that. And so as we look at that kind of breakdown, that's where the future is going to be for us as we try to address population management. What do we do with the 1%? Conversely, if you look at the 50%, they account for less than 9% of the total expenditures. The 50% of the patients, their variation, they don't change a lot. They generally stay where they are, but the frequent flyers, as they have been coined, they turn out to, you can see the difference in the admissions, 3 to 4 admissions, 72,000 per episode, more than 5 admissions, 122,000 per episode. So the more that you, statistically, the more you go into the emergency room, the more expensive it is on each visit. So it's crucial for us financially and clinically to find ways to address this. And what we've found is that the more efficient markets become more efficient by addressing some of these issues. What we need to do as a collective, I would argue, is find ways to be successful in the business model of the future. We have to find ways to increase quality and decrease cost. And this is one of 1,000 different ways that we can do that. We can increase quality by helping people who go to the ER 300 times a year. What if we can keep them more healthy and drive that cost from $5 million to $3 million? We've increased the quality and decreased the cost. Did I say that right? I did. Yeah. We can increase that quality and decrease that cost. Some of the successful response to population health will include that overall patient health, expanding upon the networks that we currently have, and finding partners that include multi-specialty physician groups, hospitals, rehab providers, pharmacies, everybody who's involved in this. Let me tell you what I think this can do for us in the future. So here's some population management math that we've done in our organization. So we're going to suggest that there might be 2,000, if there are 2,000 patients on a primary care panel and the admission rate is about 5%, my quick math tells me that's about 100 admissions a year. What if we're able, by some kind of population health magic, to decrease that by 5 to 10 admissions a year? Let's say 10 admissions a year. That means that the organization, under a fee-for-service value, could lose between about $140, give or take, $1,000 per year. If we multiply that, and if we drive that utilization down a lot, then we're going to drive a lot of revenue out of the hospital. Hospital administrators like me get all stressed. But we can address that. What we don't see is we're thinking on the curve one mentality. We can address the curve one mentality as we drive those admissions out by broadening the scope that we provide services to, and that's only an additional 10 physicians that we can add to our service line to make up for that and be prepared for a curve two model even under curve one mentality. It's not like if we do the right thing and we drive admissions out that we're destroying our organization forever. We can fix that by improving the quality, broadening the market we serve, bringing those patients back in. We save ourselves under curve one and we prepare for curve two. The interesting thing from a scientific perspective is the application this has. We've been talking a little bit about this at the University of Colorado and trying to prepare for what this might mean for us. But some of the studies from Vanderbilt have shown us that we can specifically design responses, drugs, specifically for the specific person. We can find out what their molecular makeup is, they will respond to. If we go back here, you can see that antidepressants only work for 38% of patients, asthma drugs for 40%, cancer drugs, they're ineffective on 75%. Sorry, I had that backward. So if we can follow what Vanderbilt seems to be having some success at and identify what works specifically for the person, then population management takes on a whole new meaning, because we're going to have the data from all of the people in our system on how best to address that. We'll be able to go to them specifically and tell them what we can do for them to address some of these needs. And we can keep it in our medical record, and we can keep a chart on each patient on what works, what doesn't work well, and what we can bring it up to address that. So, and I didn't get that. There's a plug for my book. That's awesome. and more people can tell you about that. So that's my story, and I'm sticking to it, to a group of people, only one of whom I'll ever see again. Thank you for having me.
Thank you, Rulon. So I'm going to ask one question before I open it up to the audience, unless, Jane, do you have a question also? No. Okay. So my question, Rulon, is, so obviously your organization has been very value conscious and doing continuous quality improvement for a long time. And one of the things is, I noticed on one of your slides, so you went from no employed docs to, in 2008, 25% employed at your, and where are you now in 2013?
It's not much. It's 28 or something like that, but it's about 300.
Okay. Are there different barriers with engaging the independent physicians from the employed, and if so, what are they?
Are there different barriers?
Yeah, different barriers, or, you know, what are some of the tensions on some of the, let's say, initiatives that you're doing on the quality improvement and engaging the doctors?
So the answer to that is absolutely yes. So as we've started to employ physicians, we've run into a lot of barriers. First of all, who wants to work for an administrator? So we've solved that by creating a physician-led structure so that physicians are leading physicians. Then when we create a model that seems to work financially and clinically, then we've got physicians that, quite honestly, we don't want employed coming in. And so then we've had to create a matrix about how do we decide who comes in and who doesn't come in. And I'm going to talk like an administrator here. There are clinical barriers that the physicians will disallow for a physician to come in. If they just don't feel like they're good doctors, then they can't come in. If there are productivity barriers, then they can't come in either. And we will have primary care physicians who will see four patients a day, and some who will see 20 a day. And that just presents its own problems, and we've got to be mindful of that.
Right. So you've developed some standards, and then you just want the docs to meet the standards.
The physician leadership developed 100% of those standards.
So I'll open it up for discussion to the audience, please.
Are they going to be mean?
Hi there. Can I ask 3 questions?
Sure.
That was the first one. My name's Bob Jays. I'm a internist and geriatrician and home-based medical provider in Washington, D.C. at George Washington. For the first speaker, that was one of the clearest discussions of the readmission numbers that I've ever heard. I'm curious about what I've read in the papers about hospitals identifying people as like, I guess they put them in the emergency room and like in a back room, and they don't admit them, but they kind of work on them for a while. How does that, what's that called, and how does that affect the readmission numbers?
Yeah, well, okay. I would call that an OBS stay.
An OBS,
that's
right.
how it would be coded in a Medicare claims. So there is no doubt that the practice of putting people into observation is exploding, because that's a way for a hospital to not readmit. I personally don't know whether that's better or not as good for patients than being readmitted. So, you know, we do know that most patients uniformly say they do not want to be admitted to the hospital. They certainly don't want to be readmitted. Patients often don't know the difference. They don't know they're in an OBS bed as opposed to being admitted. But in a market that has real high utilization of acute care services and real high readmission rates, just as a quality improvement person, I don't know whether or not that constitutes improvement, moving from admission to OBS. Within Medicare, it's a huge problem, because then they don't get their 3-day qualifying stay to have their SNF care paid for. And so patients and families will often refuse SNF admission when that's what they need. So, for instance, when we reviewed a lot of these readmission records, I mean, seriously, at the 2 hospitals here in Colorado where I reviewed the discharge and the readmission, something like some huge proportion of them, 20 or 30%, the hospitalist basically recorded if this patient doesn't go to SNF, they will be readmitted in 5 to 7 days. I mean, sometimes they were that specific, and sure enough, the patient was. So this practice of OB-STAY is going to make that worse. That's a policy issue that CMS has to look at. Bundled payment should help take care of this. So there is a post-acute care bundle allegedly coming soon. Whether or not it constitutes a better experience for the patient, I don't know. I wonder if you're talking in part, though, about hot spotting, which is basically what Rulon, was talking about in terms of identifying your most frequent utilizers and trying to wrap a different type of service model around them. That, I think, is an excellent way to proceed.
Well, that was my question for our second speaker. Next week, I will actually be at the American Academy of Home Care Physicians meeting, and a lot of the home care physicians at those meetings were talking about, gee, how can we work with our health systems to take care of those 15 people that are costing $15 million or whatever. Has your system thought of working with home-based providers to deal with, for example, that man that's in there 302 times?
It was a woman, but yes.
A woman, oh, okay.
Yeah, but we have, and so we have tasked the group. We've put together a group across our system to put together a primary care strategy, and one of those primary care strategies is to develop a response to that. But I believe that less than half of the health systems in the country really understand this problem and are addressing it. I believe that if I were a home care physician, I would go visit with my hospital administrator and say, I can save you $15 million, and my salary is only 10, so it will be awesome.
Thank you.
Hi, I'm Rick Lofgren. I'm the Chief Clinical Officer at UHC. I'm afraid, Roland, I might be the second person you'll see again. For those in the audience, UHC is a consortium of 119 academic medical centers around.
And those were their slides we stole.
I was going to come to that. But I liked them, actually. And we're 100, and for the people in the audience, we're probably the organization that gives you, amongst other things, all your comparative data. And I had a comment, and I'm not sure it's either supporting or pushing back on what you said, Dr. Brock. But you know, we've had a number of initiatives within the 119 academic medical centers, of which we've seen really incredibly sustainable changes like reductions in central line infections. We've been looking at our data as it relates to readmissions, and I can tell you that in 119 academic medical centers, after really a tremendous amount of effort, money, thought, boost, not boost, the rate went up. Amongst our HEN players, of which we have 76 hospitals who have spent time in collaborative spending an enormous amount of money, time, and resources, we're up about 1.6%. I am really underwhelmed that we have any answer, because every time I hear a story about an institution where the rates have gone down, I give you an institution where they went up, and I'm not so sure we're not measuring random variation. So you sort of alluded to it because that's how CMS is counting it, and I think that's part of the issue here. But in the end, is that we're not seeing any kind of, in fact, the idea that these are as preventable as the IOM suggests is I'm not seeing it in the data, and I'm not seeing it amongst 119 really smart institutions who are spending lots of money trying to figure this out. The second comment I'd make is really, which is dovetails the slides that Rulon showed, which is our research from this year. What he didn't show was, in fact, the impact of SES on heart failure, which was profound. It's not 4%. The likelihood of being in one of those high-cost buckets was probably 2 to 3 times higher in the lower socioeconomic group. Whether it's a community or whether it's the patient, the reality is that people who come from lower socioeconomic groups have a dramatically higher risk of being a very expensive patient, which supports the idea that, in fact, the policy as it's being rolled out right now really is going to punish or penalize those facilities that actually have a disproportionate share of disadvantaged populations. So I don't know. In fact, in the end, it's going to just be a tax.
Lots of luck with that.
Are you talking about a jump in your readmissions per discharges measure?
Yeah.
I believe that's the problem. probably you are doing a better job at admitting sicker patients, because probably you are working with your outpatient medical and non-medical providers. Well, I would hope that you are. So you know, I think when the readmissions penalty was envisioned, the basic aim for that was to ensure that we were not managing chronic disease using acute care resources. But when you think about that, project that out. Once you've taken care of that, and the silver tsunami ensures that you're going to have more Medicare patients to fill your beds over time. But once you've taken care of that, let's say, and your community is managing chronic disease in the community, then the folks who are getting admitted are presumably appropriate for acute care services. And you're probably admitting fewer per thousand, but your readmission rate may go up once you've solved the easy problem.
So the issue here is that in the value-based purchasing, as you do your little calculator, as Roland's done his calculator, and I've seen his calculator for Colorado, the things that you can move, readmission doesn't. It befuddles me why it in fact remains as part of the calculation going forward. There's enough problem with the measure, the risk adjustment, the SES piece of this, that it really is going to have an adverse effect. And I think it's been pretty clearly documented it's going to have an adverse effect as it gets rolled out.
So I can't speak for CMS, but CMS is very aware of this sort of disconnect. I know that we have encouraged solutions to look at, you know, essentially giving credit to hospitals for being part of a community in which readmission incidence is going down, even if their proportion readmission seems to be either stuck or going up. With regard to the safety net hospitals and folks who serve difficult communities, like I said, this is, I hope, where my next work is going. I just want to point out that so from the hospital's point of view, calculating a risk index for an individual at the time of discharge and factoring socioeconomic status into that, that's not a very powerful predictor. And so two of the communities that we worked with that I showed you on that map, one was Harlingen, Texas, which is just down the road from McAllen, you know, the ATM guy, and one of them is Tuscaloosa, Alabama. Those are both incredibly poor, challenged communities. And both of them did very, very well because those are poor communities in which family support, so particularly Harlingen, where grandma, for all we know, would like to die alone, but she can't because she lives in a home with, you know, 4 generations. So by proper recruitment, engagement, and involvement of extended families, they made it like a 20% reduction in their readmission rates, as opposed to Camden, New Jersey, where you have poor people who live in isolation, and that was not effective there. So that's why I think that if you serve a challenging community, that to me is the community infrastructure that's really more of a problem than that individual's socioeconomic challenges. If you're a community-based hospital, you know, you also have to demonstrate that you're contributing to the community to keep your tax status right. I mean, I'm not an expert on that part of the ACA, but so I actually think that hospitals in challenging communities need to get really involved in what is the social support infrastructure like for these people that we send back, and how can we leverage that?
You raised some important points. You said the individual hospital interventions really don't make a difference, and I think actually there's pretty good evidence actually they're not all that useful. We can come back to that, but the community one it does. I'm good with that. They might even be true. The problem is that the penalties start tomorrow, and if I'm sitting in Philadelphia, there's nothing I can do, and yet you're going to be the Medicare's taking resources away. It's really really surprising that, given the wealth of information, how adversely this is going to affect, and the data and the numbers around it, that it persists.
Can I just say that if anybody asks me a question that hard, I'm leaving. So let's just be warned.
I'm just going to tell you, Roland, I like the slides.
Yeah, no, you are awesome. Okay, again, good luck with that.
Thank you. Well, you know, so I can tell you we want to adjust the hospital readmissions data by neighborhood effects of where the person lives, just to demonstrate if we can improve the model. So the current hospital compare measures have a C statistic of 0.61. So they were a good starting place, I think. And I do think that the presence of the hospital readmissions penalties has been very good for getting people focused on the attention. And when you look at readmissions per thousand in this country, they're going down, and I think they wouldn't be without the penalty personally. However, I'm not writing paychecks out of a hospital like you guys probably are. I don't know.
Hi, thanks. My name's Mary Pickett, and I'm from OHSU. So I work in a academic, hospital-based outpatient area, and parts of the year I ward attend. But I'm fascinated by how Medicare has not found a way to entice the primary care doctor into the hospital stay with any financial incentive. And I've been told that if you do visit and document your participation in the hospital plan, that perhaps the hospital could charge a time-based fee for the internist that's a little higher, but nobody's brave enough to try this system. And I understand that you can't, as a primary care doctor, bill for care plan oversight when a patient's in a SNF if you're in the clinic, like you might be able to for a home health visit outside of a SNF. And I am fascinated by the care transitions model tendency to bring in a third-party player instead of finding a way to encourage the primary care doctor with a financial incentive to come to the hospital or meet the patient at that site. Because I do find my colleagues will visit patients when they have time, if they have a relationship with those patients, but they'll categorize that visit as a social visit. They don't always have a chance to interact with the team. They're doing a breeze-by to make sure the patient knows that they're aware they were hospitalized. And boy, it seems like your idea of the care management rounds for transitions makes so much sense. Why haven't we come up with a one-time payment to the PCP for that meaningful visit to the hospital?
So first of all, there is now a care coordination code under Medicare that you can bill. And I'm sorry, I'm not 100% an expert on this, but you have to have seen the patient, I think, or contacted the patient within 24 hours of discharge. So for all I know, that can apply to 24 hours prior to discharge. I'm not sure. And does it before or after? It has to be after. And I understand that the reimbursement is significant with that, like $200 to do sort of primary care coordination following discharge. In terms of paying for before, Medicare does not pay for that. Rocky Mountain Health Plans was just located here. They started doing that about 10 years ago, and they attribute their phenomenal numbers in part to that practice. If you are a primary care physician, you drop by and just sign the chart, you can bill $80, I think, to Rocky Mountain Health Plan. So I assume some health plans are probably doing that. I don't know if you guys are, yeah.
So we've spent the last portion of the last many weeks preparing for that, because accountable care will force us to provide those services with primary care physicians, and which is also part of our primary care strategy, is how do we get them back engaged, providing services at a level that provides a better outcome at a lower cost. And I think the model is in place. It's the Curve 2 model, but if we all believe we're moving to Curve 2 and accountable care and bundled payments, then there are people like me spending a lot of time on how we're going to do that. So I think the plan is in place, to be honest.
Is there time for one more question?
I think there is.
Well, the first question is if for the person with 30 admissions, my friend and I were talking about, why don't you just buy him a mobile ambulance? It might be less expensive than for $5 million.
That could be.
And the second issue, I thought very interestingly, a lot of times the patient doesn't have a lot of skin in the game, and I've been interested in ideas about behavioral economics, where you might put a patient has skin in the game or receive some sort of bonus or award or something. When you think about you're spending an average of $8,000 on average for every man, woman, and child, but these are obviously high-cost conditions. Have you done anything about, I don't know whether it might be paying a bonus, cash bonus, cards, or something else for some of these people for cash transfers if they meet certain performance guidelines, like they're getting their medications refilled or they're keeping their, their 1 week appointment after discharge or something like that.
Yeah, there's some very specific rules about what you can and can't pay patients for their
right, but there might be experiments that you can, taking ideas with behavioral economics potentially get a waiver for.
There are, and I believe that in fact I wrote a book on it. Flip that last slide up there. Go back one slide. That to me, it's the frustration has been that I think we've created a plan that incentivizes people to use the system, and their behavior will follow that. We give them every opportunity to use the plan, to use the system. Then, to the surprise of no one, it becomes too expensive, and then they reduce payment to providers. And that to me, but until, I don't see a solution to that until there's more providers than other voters. Because right now, I think it's a Kenneth Arrow political concept, personally. I just don't see it changing.
Okay.
I know, depressing.
Well,
we're going to work as a part of an accountable care organization to get people into the organization, and we are going to mine the data and provide them every personal incentive to get better. And we're going to help them understand and provide them services to improve their life. That is the motivation that we have.
It's again, I'm kind of skeptical, and a couple ideas or big data ideas are, for example, many people might have a CVS or a Rite Aid card or a Walgreens card. So when you go in, not everyone's getting care from a VA where there's great databases and if someone's getting their medicine refilled. But it could even be a partnership with a local or regional pharmacy chain, because these people are scanning, when their cards whenever they go for a refill, and if they are or not, they could be getting, discounts or coupons or something that's of value. I'll give you another example. I was on call a few months ago for our practice, and I got a call from a patient who was concerned that he ate recalled spinach. There was a question mark of an E. coli outbreak for 0157 in Pittsburgh area. And I thought at first that the guy was maybe just anxious, because this is my area of research. And I said, well, how do you know? I thought maybe he just saw a news report. And he said he got a phone call from the local pharmacy, local supermarket chain, Giant Eagle, because he scanned with his card, which gives him fuel perks and discounts. So they knew the lot number, they knew the SKU. So it made me think about, I wonder if you could design a program where maybe he got extra fuel perks or discounts if he consumed healthier foods. You might not know that the healthy food is going to him, but you knew that in his household he was getting more healthy foods. And I'm just wondering, maybe about potentially partnerships between these national food chains that have these frequent flyer cards or whatever you want to call them, value cards, and hospital chains and other kind of provider insurance networks.
In the accountable care diagram I drew, I specifically put pharmacies in there because I think that drug utilization is so much a part of our future, and we've got to find a way to drive that down. I will tell you that we have just because of federal criminal restrictions, not pursued anything to in the form of giving kickbacks to patients. But maybe there are things we haven't looked. Maybe there is. I don't know. But I will guarantee you we will go back and look at that, because I have not thought of that. Because we're going to have all that data. Everything is going to be there.
Right.
Yeah. No, thanks.
Good luck.
Yeah.
Thank you all for your questions. I thought it was a great discussion, and Rulon and Jane are really great talks. I really appreciate it. And I guess that's it. Thanks. Thank you so much. That was fun. That's great. Thank you so much. You're really good. So I think it worked out.